and welcome. I'm Dr. Tina Moore, and I am going to be presenting today in this webinar on why women need testosterone too. I've been generously invited by Cameron at Fullscript to be a part of this, and I'm super excited to be able to reach all of you and to have so much exposure to so many cool practitioners so that I can share this passion with you. I'm going to tell you a little bit about myself so you understand why I'm so passionate about this topic, and then we'll proceed. So we're going to be here for about an hour, and I'll do a Q&A at the end. So if you want to stick around, please do. I don't want to waste your time. I know it's valuable, so I will try to get through this as fast as possible. Let me make sure my screen is going. So I'm Dr. Tina Moore. I am here because I have a passion for empowering women in particular to be strong and live their most optimal life. I have a whole online platform based around the term pain-free and strong. I have a book on the topic. I have a podcast on the topic. I have a Facebook group on it. And I really have found a niche where I didn't realize I would with women in particular. So you can find me at Dr. Tina on just about every platform out there, and I hope you will. Instagram is where I'm most active right now, and I throw down a lot of fun content on there. So who am I? I'm a chiropractor and a naturopathic doctor. I did both programs concurrently, and so I have a particular interest in how musculoskeletal medicine ties into systemic medicine. And I didn't become a naturopathic doctor or a chiropractor in particular and then have to learn the other. My paradigm was that they both were happening simultaneously in my brain. So the way I think about things is often a little bit different than either or. Not better, just different. I have specialized in regenerative injection therapies for over a decade. My mentor was Dr. Rick Marinelli, who was a big deal in our profession as a naturopathic doctor. He really brought naturopathic pain management to our profession some 30 years ago. And he taught me prolotherapy. And I spent 20 years following him around watching prolotherapy. I joke that I have drank the prolotherapy Kool-Aid. It's in my blood. I have known prolo more than half my life. And I don't think I would be walking without it. So I am a big proponent of pain management, and I've taken that on as my specialty in my practice. I also have a particular interest in bioidentical hormone replacement because the two tie together so intimately. So I'm well versed in natural pain management. And this is personal. About 3 years ago, my hip, the way I term it is my hips started to melt. Out of nowhere, out of seemingly nowhere, I started having hip problems. And I chalked it up to the fact that I love to lift heavy weights, and I was deadlifting way too much weight, way too often. I was PRing too often, and I ended up tearing a labrum. But my hip just sort of, what happens in musculoskeletal medicine is once an injury occurs, sometimes that's like the straw that broke the camel's back, and everything starts to disintegrate from there. And one hip went, and just when I got that one under control after about 2 years of regenerative injections, figuring out pieces of the puzzle and rehabilitation and a lot more strength training around it, the other hip started to go. And the minute you see two joints simultaneously doing something bad, that should raise your red flags. That is always a systemic cause. It wasn't until this past summer that I realized it was testosterone deficiency. And so, of course, I went down the rabbit hole like I do, and I found so much information. Some of it I knew, and a lot of it I have stumbled upon and put together and just increased the amount of knowledge I had and filled in some of the dots. So what we normally think of with low testosterone is men, right? It's generally considered only a male issue. That is how the medical profession presents it, that it is only a male issue. We often think of erectile dysfunction. Something's popping up on my screen. We often think of erectile dysfunction or problems down there as one of the first symptoms. Although I'll tell you from practice, before there was these testosterone clinics, I think I had one. My mentor passed away, Rick Marinelli, in 2013 of cancer, and I took over his practice in 2010, I believe. And he had a very heavy testosterone practice combined with a regenerative practice. The two go very beautifully together. And I was taking care of a lot of men and prescribing a lot of testosterone very early in my career. So I learned a lot quickly. So most often erectile dysfunction was not the top of their list. I was noticing testosterone deficiency syndrome and symptoms before they were complaining about their penis not working right. It is a very motivating symptom, but it's not always the first. Muscle loss might be more notable, or lack of gains in the gym, loss of stamina. They would develop a pot belly. difficulty healing or just not coming back from injuries as quickly. That would be usually what brought them into the clinic in the first place. And then lesser considered symptoms or side effects of low testosterone would be, and so we know these as functional medicine and naturopathic physicians, diabetes type 2, heart disease, osteoporosis, depression, apathy, memory issues, not feeling themselves, mood swings, joint pain, and then I think most notably sarcopenia. I think sarcopenia is the beginning of the end for a lot of people. And I think we're seeing sarcopenia in much younger populations than we have in the past because people are so deconditioned and there's such a lack of exercise and strength training happening in our country, particularly the US. So these are all the things that you would generally see. I would, as a aside, clinically, what I would see is I'd pull up their pant legs to check out their knees and to do an assessment, and I would see that they were losing shin hair. And that was one of the things that would cue me, is that there was a loss of shin hair. And I would say, oh, hey, we should talk about your testosterone. And the first thing out of their mouth would be, well, I'm fine down there, if you know what I mean. I'm like, not talking about your erections, talking about the fact that we have a lot of other symptoms that are adding up here, and we might want to check that out. So what's it got to do with women? Women and testosterone, not really talked about that often, not really considered a big deal. It's often only considered a male hormone. Again, the medical profession is really not up on the tip on this one. There is a great article called Testosterone Therapy in Women, Myths and Misconceptions, by a woman named Rebecca Glazer. I encourage you to check it out. I've given you the reference here. Abandoning myths, misconceptions, and unfounded concerns about testosterone and testosterone therapy in women will enable physicians to provide evidence-based recommendations and appropriate therapy. It's a good read. I encourage you to find it. You can find the PDF online. Here's the reality of testosterone therapy for women. If you start going into the research, if you're a female, you're going to become, or a feminist, you're going to become enraged. It's really, really frustrating. The amount of dissertations that I found written by male practitioners basically discounting that this therapy is even remotely necessary, and just completely discounting all the signs and symptoms, and even discounting DHEA. It's infuriating. So aside from getting angry during my research for this webinar, I learned a lot about how the medical system, and it's no surprise, it's a pretty patriarchal driven profession, as we know, and I won't get into the politics of it, but this is no different when it comes to testosterone in women. So testosterone deficiency in women is not even recognized as a diagnosis. If you can find an ICD-10, please shoot it to me, because I could not find one. Hypoactive sexual desire disorder is defined in men, but not women, although there's a drug out there now that increases nitrous oxide for women, and they're talking about it a little bit more, but really no androgen therapy based discussion on HSDD. 1 in 10 premenopausal women in the US suffer from HSDD. That's premenopausal. We're not talking postmenopausal women. You know, in society, women lose their hormones as they pass through menopause, and they're considered dried up old ladies who don't need to have sex anymore, and which is entirely untrue. I'm almost 46 years old, and I can tell you from personal experience and from talking to all of my girlfriends in my age group, this is absolutely not the case. So it's really concerning that 1 in 10 premenopausal women are suffering from this, and nothing is being done. Not to mention all of the other impacts and symptoms of low testosterone, which I'm going to take you through, which are severe. This is not just about libido. While women are barely recognized as having libido issues, doctors certainly aren't looking at other symptoms of low T on the regular. I know I wasn't. And personally, having done the research I've been doing the past few months, it was always on my brain, and I would always discuss it with patients. However, there's a very clear type of patient, I'll describe her at the end if we have time, who you can sort of put in your head that I know has low testosterone. And their pain was unfounded for the amount or lack of trauma that had been induced. So they would present with terrible lumbopelvic pain generally, or hip pain or knee pain, and they would not generally have a huge traumatic insult or injury. It just sort of started. And thyroid can be implicated for this. And I have a whole talk, maybe some of you have seen it, on thyroid and pain, but that's not always the answer. It's part of the answer. So, and the other hormones are part of the answer too, but I regret considerably not putting more people on testosterone therapy. The problem with women and testosterone is the minute you mention it, in passing. Not guys are already hard enough to convince, but the minute you mention it to women, they're like, oh, no, no, no. They think they're going to grow a mustache and turn into the Hulk. And so, I mean, it's hard enough to get them to strength train. So this is really, it was always such a difficult discussion, and it took up so much time in the office that often I would just be like, okay, we'll start with the progesterone and the estrogen, and we can work towards the testosterone. When in all honesty, looking back, I should have started with the testosterone. It would have cleared up a whole lot of symptoms that are looking like other hormonal symptoms. So testosterone for women, T therapy for women remains controversial and considered lifestyle therapy. It's literally only talked about in terms of libido, which is considered lifestyle therapy. And as somebody who is, I am active, I am healthy, I know a lot of other active, healthy women in middle age. We enjoy sex, we enjoy having a strong libido, and to have that be removed from your life is like taking a part of your identity and just killing it. It's like having a part of you die. And that's how women will describe it. They'll just say like, something went wrong and I don't know what it was. And oops, and I feel terrible. So it's libido isn't just about libido. Libido is often a way of communication with your partner. It ties into that. You know, the way that you define yourself as a sexual being has a lot to do with how you proceed through the world. So to have that just suddenly like taken out of your life, it's like someone flipped a switch and turned it off. It can be really devastating. Okay, common low testosterone symptoms in women. So sexually, they will be disinterested in sex. And I'm not kidding you. It's like someone flipped a switch. They will, which often leads to negative body image because you don't even understand why you don't want to have sex. So you start beating up on yourself. There can be weight gain, which I'll get to in a minute, but it's like out of nowhere, you get the middle-aged middle and you're like, what is this? And that can lead to a lot of negative body image. You start to avoid intimacy, inability to orgasm, pretty concerning for a lot of women. And then they show up in my office wanting me to do PRP into their clitoris. And I'm like, well, let's back up. You might not need to have needles stuck into your vagina. We might want to talk about your hormones. Low self-esteem, loss of identity, and ultimately depression. And it's really devastating on relationships, especially relationships that have a strong sexual orientation. It can really be devastating between the woman and her partner. Systemically, they're going to complain of fatigue. Often there's insomnia, like they literally will go from sleeping like the dead their whole lives to just crazy insomnia. And what do? We chalk it up to progesterone. We try to give them micronized progesterone, which may or may not help. We might give them some pregnenolone or some neurosteroids, but maybe it's just testosterone deficiency. Migraines are a big one. Belly fat and weight gain is super common and it sucks. Decreased stamina, and I'm talking about in all areas, like in the gym, in the bedroom, zest for life in general. There's just a decreased stamina, loss of memory, where they just can't recall simple things at all, and the list goes on. So more symptoms that will show up. There's often a loss of skin tone. So they just kind of get saggy and droopy. And this happened to me. All of a sudden, my face just started drooping. And I was like, what is going on here? This is crazy town. Now, that could be low progesterone. That could be low estrogen as well. As we know, those of us who do a lot of hormone replacement therapy, but there's just a loss of turgor in general. Breasts will also start to sag. There's just kind of a general looking old, feeling old picture happening. Loss of integrity of the skin, and then cellulite may show up. I had cellulite show up for the first time in my life, and I was like, what is this? And I'll tell you what, since starting testosterone therapy, the cellulite went away. There's reasons for that, and they're speculative, but it's one of the symptoms. Mood, there's a loss of the zest for life, and that is probably the most concerning. It's like somebody turned the lights out, and it's a depression you cannot shake. Feeling like something is wrong but can't put your finger on it. I literally was running around to everybody I knew for 2 years saying something is wrong, something is wrong. And I'm good friends with Carrie Jones, Dr. Carrie Jones. You guys might know her. If you don't, you should if you're looking at hormones. And she, ran me through the Dutch test and all that. And we put our finger on a few things, but still the flags of testosterone did not come up. Although looking back, it was low. Here's the thing, and I'll get to this at the end. You have to dose the person according to how their body is used to being dosed. So I have always had high testosterone and lower progesterone and estrogen. I tend to run very low on the estrogen side of things. I feel good that way. That's how I identify myself. That's how I am happiest. That's how I feel the best. So, and I am also very active in the gym. I train like a warrior. I do kettlebell stuff. Like it's crazy town sometimes. So you have to look at the person in front of you And if they're telling you something's wrong and their tests are saying everything's fine, you have to put it into context of what they're used to feeling like and what they may need as an individual. This is why we do individualized medicine. Anxiety and depression is huge. Anxiety is a big one. It's like unremitting anxiety. Inability to organize thoughts or things or life or anything in general. Is this sounding like your typical peri and postmenopausal woman? Because it sure does to me. Loss of motivation, loss of joy for living, loss of sense of well-being. On the body immune side of things, autoimmune disease may just creep up out of nowhere. We all know this, especially with the inflammatory arthritic conditions. We know that these show up in that age group. The 40 to 50 to 60-year-old women are who get rheumatoid arthritis, are who get a lot of these inflammatory arthritic conditions. I have a whole talk on that too. Some of you may have seen. Dry eyes can be a common one. Pain is huge. And I'm going to double down on that in this because that's my world. That's what I pay attention to. Arthritis, joint degeneration, osteoporosis. The reason these are bolded is because this is what people are going to walk into your office complaining of the most. Pain. 1 in 5 patients presents to any doctor's office with pain. You need to know how to deal with it. That doesn't mean you need to know musculoskeletal medicine, but you need to be able to quickly, and I hope by the end of this, if there's any objective I have here, it's that when you see a woman in middle age walk in with pain, especially if it's bilateral, I want you to run her testosterone and very seriously consider making sure it gets supplemented or that you do all the things to support it. And I'll go through some supplements at the end. Lack of strength is a big one, and loss of balance. We think we're just getting old. We're not. I literally lost balance in the gym. I couldn't do unilateral movements anymore. I literally couldn't do lunges. It was like, what is happening? What is wrong with me? And it's real, and it's frightening, and it sucks, but it happens so insidiously that you just don't think much of it. Sounds a lot like getting old, doesn't it? I mean, this is pretty classic what most women are experiencing in this country. This is your typical picture of an older woman with that Dowager's hump, you know, the kyphotic curve of the thoracic spine due to osteoporosis. It's also exacerbated by hypothyroidism. There's a whole lot of reasons why the spine starts to do that. Malnourishment, microbiome dysfunction, all sorts of things. But sarcopenia is huge, and that is the loss of muscle mass. It's poverty of the flesh. That's literally what it means. And so the body starts wasting. It's not just, oh, they're not exercising. They literally start to disintegrate their muscle tissue. Osteoporosis, also huge in women. I call it the skinny white girl syndrome because that's what it is. It happens in Caucasian women. If they've got light hair, light skin, light eyes, you better get them strength training or they're going to be concerned. Now let's back up a second. What happens to a lot of women as they age significantly? They end up disabled because of hip issues or hip fractures. And often the hip fracture happens before the actual fall. And we all know this too. Hip fractures are the kiss of death. The chances of dying after a hip fracture are huge. They're particularly huge in men too. So what happens when you have something deficient in the body and now you've got sarcopenia, wasting of muscle, and you've got osteoporosis at the same time, and you have balance issues? You're going to break a hip. So perhaps testosterone therapy might stem this this total, like, it's pretty much a urgent situation at this point of how many women are aging poorly and going to break hips in the coming future, especially with the boomers getting older. We're looking at hip and knee issues like crazy. So it's a bit of an epidemic. I want you to consider testosterone. So memory issues, depression, there's diagnoses and drugs for all of these conditions, just about, but I want you to consider low testosterone. It might clear all of them up because we know that Fosamax is crap, and we know that a lot of the drugs and the remedies for these are not great. So let's consider something simple and safe. So maybe it's low testosterone. Interestingly, women have 3 times more testosterone than they do estrogen. And this again comes from Rebecca Glazer's article. But look at that graph. I mean, if that's crazy. And look how it drops off. This is not a low hormone in the body. We have more of it than we do estrogen. It's pretty darn critical. And it's not always clear cut. I know people get freaked out about testosterone. I'm going to show you a slide in a minute that basically discounts that nonsense study that came out several years ago saying testosterone was dangerous. That was a bad study. The numbers were done poorly. But there's adequate levels, and then there's frank deficiency. And the medical world the allopathic world only looks at those 2 things and says, well, you don't have a frank deficiency. And this is for all hormones. You guys know this. You don't have a frank deficiency, so therefore you must be adequate. that's a huge, huge gray zone in the middle where physiologic dosing, I did not spell that right. Physiologic dosing plays a tremendous role in quality of life. And I will say this for thyroid hormone, I will say it for progesterone, I will say it for estrogen, I will say it for testosterone. Any woman over 40, you should start looking at physiologic dosing of all the hormones, because the quality of life that she will endure is so much better than if she's deficient. You can do a lot for people. So if 1 in 10 premenopausal women present with low libido, it's a problem, right? We talked about this earlier. This is rarely considered worth treating. In men, libido and erectile dysfunction is often a late symptom, like I said, but that is certainly worth treating. There were millions of dollars spent and very few studies needed to push, Viagra through, but yet they still won't push through an androgen supportive drug for women. And there is one out there that's an estrogen with a synthetic, non-bioidentical testosterone attached to it, but the FDA just won't push this stuff through. It's not considered important. So women having sex obviously is not important according to the FDA. Still no FDA approved androgen therapies for women. Why prolong the misery, especially if there is pain? So this is what I want to come back to. If the patient is female and she presents with pain and she's over 40, I want you to consider looking at testosterone levels. You might save them a lot of aggravation and several joint replacements, and I'm not even exaggerating. So cold and achy, this is how women will present in my office most often. They will tell me that they're cold and they're achy. And I live in Portland, Oregon, and it's gray as heck right now outside. It's rainy all the time. Like, this weather's like kryptonite for anybody with any kind of joint pain, but they just get cold and achy, and they'll tell you that. Women will, more often than men, will report this feeling. I don't see it often in men. And we do know, so something I did in my practice, because I had to get people, here's a clinical pearl for those of you who can prescribe testosterone, I had to get people optimized for PRP and stem cell procedures quickly, because sometimes they were flying in or who knows what, but we had to get them going because their joints were going fast, and we had to get them treated. We didn't have 9 months to optimize themselves and nudge them into hormonal perfection. We had to hit it. So I would use hormones as almost an emergency measure, and I would dose them with testosterone. And I would tell them, I am going to dose you until you get hot, and this is in males predominantly, until you get hot, until you get horny. Truly, that was what I would say. If the minute they got warm and hot, I knew the testosterone was on board. Any of you who have taken it know this feeling. You get very warm very quickly, and then they would tend to have their libido increase. That was when we treated them. That was when I would go ahead and do the PRP or whatever else. I would do prolotherapy before that, because it was important that they were in optimal healing mode to heal well from prolo, but really I was just trying to get their pain down and get them dialed in. Then I would hit them with something stronger. So this is not a regenerative talk. I just wanted to share with you how I did that. So they can't get warm and everything hurts. That's what women will describe. Especially in the winter, it can be really painful. Like, your whole body hurts and it's miserable. So what's the differential on this? Fibromyalgia, osteoarthritis, hypothyroid, myalgia, like all these other diagnoses get thrown out there and treated, but no one's looking at the root cause, which might be low testosterone. Consider any woman over 40 following a massive bout of stress or trauma, consider testosterone therapy. So consider it in any woman over 40, especially if they've had a massive bout of stress or trauma. And that trauma may not be physical, it may be emotional, it may be life, who knows. But if their HPA axis got slammed, which is what happened to me over the course of many years, but over the course of the last year, my daughter almost died, my mom almost died. I had 3 dogs die in 2 years. My favorite dog died in the middle of the year. My relationship ended. I moved several times in the past few years. Like, my HPA axis was giving me the finger. And the end result was major testosterone drop off for me. I always ran a little bit low as I was aging, but it just tanked. So low testosterone and pain. Chronic pain patients often have low serum testosterone levels. You can look this up and Google it. You can find, I've got a reference for you coming up here, but I'm telling you, it's so important that there are pain journals saying the first line therapy for any patient in chronic pain is testosterone. And also to note, opioids decrease testosterone. So we've got a bunch of chronic pain patients walking around on a bunch of opioids. Opioids also increase microglial cell activation and inflammation in the brain, which creates a upstream issue of central sensitization and chronic pain. I mean, the whole thing's a mess. Opioids are a mess. And so we've got opioids tanking out testosterone, chronic pain tanking out the HPA axis and tanking out other hormones and testosterone. So it's a big issue. And again, all of the hormones work in harmony and they all need to be considered, but often a lot of the symptoms we're seeing, we're calling it, oh, it's adrenal insufficiency or it's low progesterone. It might be a low testosterone issue. Pain depletes hormones such as cortisol and testosterone via the hyperarousal of the HPA axis. So look this up and look up what the pain experts are saying. They're saying unequivocally that testosterone therapy should be first-line therapy for patients with chronic pain. Pain is a lightning rod. Any of you who know Dr. Heidi Peterson, she was one of my mentors. She's a dear friend of mine. I still practice out of her office and or in the building she owns. And this is what she would always say to me, pain is a lightning rod. So wherever the patient's pain is, that doesn't necessarily mean we focus all our efforts there. It's telling us something. And as we walk them through their hormonal replacement therapy or whatever protocol we're putting them through, that pain lightning rod should tell us as a gauge if we're on the right track. Joint health, boy, this is the rabbit hole and I'm only barely touching on it here, but I found some crazy information on joint health and soft tissue and chondrocytes and fibroblasts in regards to testosterone. But here's the overview. Testosterone makes healthier synovial fluid. So it makes the slickness in your joints more slick so that they slip and slide. It impacts regeneration. It's anabolic, obviously. This is what I tell patients, we need an anabolic stimulus to get you to regenerate. And it's secreted in the chondrocytes. I did not know this until recently. It's a paracrine effect within the chondrocytes, and it improves osteoporosis. We know that. This is pretty critical for women who are walking around, potentially walking straight into osteoporosis. So there's the chondrogenic progenitor cells, and these are called CPCs. This study by Kohling showed that sex differences in chondrogenic progenitor cells in late stages of osteoarthritis. He looked at estrogen and testosterone, but this was the takeaway. Androgen receptors exist in chondrocytes, and we know that testosterone is secreted by chondrocytes in a paracrine fashion, so obviously something important is happening there. I've used testosterone intraarticularly in an aqueous form, amazing results. I don't suggest you go out and do that because the FDA might get mad at you, but this was years ago, and it was very effective. Testosterone influenced the expression of 3 receptor genes as well as the chondrogenic potential of the chondrogenic progenitor cells by regulating gene expression of SOX9, RUNX2 types 1 and 2 collagen. So it actually got the CPCs to go, and that's crazy and super important because people's their collagen is disintegrating, but their chondrocytes and their cartilage layers are disintegrating. Once they start, like I said, they often happen quickly. And that's what I've seen in my clinical practice, whether it's the hips or the shoulders or the knees. Once that injury occurs, once that sort of like, it's a poop storm, if you will, without using curse words, starts in the joint, it all starts going very quickly and it all starts degenerating very quickly. So if we can give those CPCs something to chew on, if you will, to make them, help them regenerate and give them a boost, then we're doing the patient a huge favor. So here is this is a great article, Testosterone Replacement, Essential in Pain Management. This was in the Practical Pain Management website from volume 14, issue number 4. I would encourage you to read it. This guy was pretty renegade in how he wrote that article. I really liked it, and I bet he took a lot of slack from his colleagues. But here is the breakdown of the criticism in the testosterone and cardiovascular events study that came out several years ago that I said was nonsense. Most of those subjects already had heart disease and entered the study at a time of coronary angiography. This was a retrospective study that were of patients who were only followed for a short time, a very short time. What's not noted here is they did not check estrogen levels in these men. So this is in men. They weren't even, which we all know is what creates the cardiovascular event, is when the aromatization to estrogen starts to happen. These cardiovascular events were actually lower in the testosterone group, which they failed to mention. And it goes on, you can read through this, but this was not a good study. So when people say, oh, testosterone is dangerous, I defer to this. So it's a slippery slope when testosterone starts to go down. The HPA axis gets hit, like I said, from, come on, any of you in your mid 40s that are female, you've lived through stress, period. If we've had children, I know men have too, but there's something particular about raising children, having them go off. This is the age when most of the children are grown. We've lived through the teenage years with them, life, career. We're supposed to be everything nowadays. We're not just allowed, it's not just be a housewife or a career gal. It's like do everything and do it well. Be the entrepreneur, be the lady boss. So the HPA axis gets hit, you end up in a deficiency, slippery slope, and then later you get frank signs and symptoms. I think there's a huge opportunity here of about a decade. if I could look back effectively, I think there was probably a decade earlier I could have used a little bit of testosterone. And again, I'm talking physiologic dosing. I would assume to consider that any woman over 40 who presents with pain, particularly of the lumbopelvic, hip, or knee regions, especially if it's a non-traumatic onset, I will add in here, especially if it's bilateral, don't wait till their joints are severe. That's a very difficult thing to rebuild. It's a lot easier to prevent it. So there's this peri to post-menopausal shift that happens. Testosterone dips, progesterone dips, estrogen dips. Some people say this is the sequence that it happens in. I don't know. I am not a hormone complete expert like Carrie Jones. Maybe we can ask her, but I think these dips may happen at various times for various reasons, is probably what she would most often say. I see a lot of young women with low progesterone, so I don't necessarily think these arrows go in order. But I do think that estrogen tends to kind of be the last thing, and we only look at that when a woman's hit menopause and say, oh, well, now we have to worry about her estrogen. I encourage you and challenge you to start looking at her testosterone, maybe even as early as the 30s. It depends, again, on her life and what her life has been like and how much stress has she endured, how much sickness, how much illness. You know, I did 2 medical degrees at the same time and raised a child on my own and built a practice and then built a whole other, empire. And like, of course, my testosterone dipped out. These dips may happen at various times for various reasons. Like I said, sickness, illness, whatever, what have you, drug interventions, who knows. However, improving testosterone levels may improve the symptoms of low progesterone and estrogen. And I will tell you this to be true personally, and I've seen it in practice. A lot of those low progesterone and particularly low estrogen symptoms tend to go away because, as we know, testosterone and estrogen sort of like, they're like sisters, right? They like to switch places. One leads into the other very readily. It's just a shift of a few molecules. There are no conclusive guidelines for testosterone replacement in women for healthy levels, for any of it. There's no conclusive guidelines. There is a book that I encourage you to read called The Secret Female Hormone by Kathy Maupin. She says that a total testosterone over 30 nanograms is minimal, and that a free testosterone of over 7 to 10 pg per ml, depending on the lab that you use. So those are just a starting point. I encourage you to do your own research and do your own, extracurricular hormone training activities and decide for yourself. Also, again, depends on your practice. I was running a regenerative joint practice. I needed to get levels up, not just kind of up. I needed to get them up because I needed to get these people to heal. So, then we would back down. So different strokes depending on what you're dealing with. Are you dealing with a CrossFitter or are you dealing with someone who's totally inactive? Jonathan Wright, if you guys don't know him, he's like the OG hormone guru. A lot of my studies started early on with Jonathan Wright. I'm a huge fan. I got to meet him a few years ago. We shared the same stage. We spoke on the same day. I just fangirled out on this guy. I was so excited to meet him. And he's such an elderly little man now. And I was like, oh my God, you're Jonathan Wright. Everything I know is from you. Not true, but I was pretty excited. So he said something that I thought was great. I've heard him say this a few times. If you ever have the chance to see him in person, oh my God, that man is a gold mine of pearls. But he said, do you know how my staff can tell when a woman is estrogen dominant or her estrogen is too high? She calls the clinic all the time, worried and very difficult. And he said, do you know how we can tell if her testosterone is adequate? She rarely calls and she's easy to get along with. So that will tell you everything you need to know about the type of patient you might be dealing with. If you've got a very anxious, nervous person who needs all the details answered and everything's always an issue and everything has to be double checked, you might want to check that woman's testosterone. So supplements to help with testosterone, really basic stuff. And you guys are going to see this and go, aha, of course. But I want to break it down for you a little bit. So there's DHEA, which I can never pronounce the full, dehydroepiandrosterone. Hey, I did it. I never get that right off the cuff. It converts to testosterone in women. I was taught by Dr. Allison McAllister that it does not convert to testosterone in men. You guys can argue amongst yourselves. I am not the expert there. Start with 5 milligrams and titrate up. I think that's a good rule. I like sublingual. I like a 5 milligram sublingual. I've given you the brand I like here. I like Da Vinci's liposomal DHEA spray. I was taught by Dr. Heidi Peterson that 5 milligrams sublingual is 3 times stronger than an oral 5 milligrams. So you're looking at more of a 15 milligram dose with 1 squirt of that. I really like DHEA for a lot of reasons. I think it's helpful for memory. I think it's helpful for brain health. I think it's helpful for pain. There's a lot of reasons I like it, but it may help support that testosterone pathway. But you don't know which pathway it's going to take is the problem. Is it going to go down estrogen? Is it going to go down testosterone? So you need to keep on that and test. Omega-3s, of course, I mean, that's a gimme. I prefer food sources. I think that eating good, healthy fish is the way to go, but it is harder to find clean fish sources these days. It improves the overall fatty acid profile of the patient and decreases inflammation, which is going to optimize testosterone anytime we can do that. So I like 1,000 to 3,000 milligrams a day with food. I was taught a long time ago in chiropractic college. I don't have the reference, but I assure you, coming out of Western States Chiropractic College, there was a strong reference that the starting dose for inflammation was 3,000 milligrams. So everybody in my practice starts at 3,000 milligrams a day with food. EPA versus DHEA, I don't know what to tell you on that. I think of EPA as being much more anti-inflammatory and DHA, I'm sorry, being much more for like neurologic, brain, nervous system, that kind of thing. So treat the patient in front of you. I think that you just need to, whatever you want to dial up or down. I like Douglas Labs Quell fish oil. They do a high EPA, they do a high DHA. I like this combo one. It has some, I think 1,000 milligrams of vitamin D. You can get all of this off Fullscript. And this is a great product. It's a triglyceride based. It absorbs well. You don't get the fish burps. This one has been the most tolerable for me personally. And I use a lot of it. I like it very much. Zinc, love zinc. I feel like a crazy person without zinc. I think a lot of women do. The first thing I think of when I see an anxious woman in front of me is a zinc deficiency. Zinc deficiency leads to anxious women with eating disorders. Put that in your memory bank. If you, especially young women, if you see a young woman who's anxious with an eating disorder, she's most likely zinc deficient, especially if they are healing poorly, but also anxious women that are older. Trust me. When patients come in to see you for pain and you're their last stop and they've done everything, there's a lot of anxiety involved and a lot of anxious women with a lot of chronic pain. So I'm well adept at dealing with them. So especially if they heal poorly, like if they cut themselves readily and it doesn't heal well, especially if they have an eating disorder history. Is it cause versus effect? I don't know, probably both. I dose kind of high. I dose 60 milligrams every night with food. I like it at night because they don't get the belly bomber. I do prefer people eat a little bit of food before bed, not a heavy meal, but do I suggest protein? Depends. Do I suggest carbohydrates? Depends. It depends on what that patient needs. But I do like to give them some supplements at night, and I like zinc to be one of them. Consider copper deficiency. Of course, you can decide how you want to supplement copper or test for copper. That's up to you. I usually don't deal or worry about it too much. And I like Designs for Health Zinc Supreme. I think it's a nice product. It's got some other cofactors in there that make it really absorbable and tolerable. I've had good luck with that. Vitamin D with K, I put in brackets, up to you. I really like K. There is science to show that vitamin K is supportive of testosterone. There's a lot of science to show that vitamin D is supportive of testosterone. So, and being as I'm a joint doctor, I like to optimize people's bones because, you know, the joints and the bones, they're all family. What happens to one happens to the other. If you've got a patient with osteoporosis, you've got a patient with joint issues. If you've got a patient with joint issues, you've got a patient with bone issues. It's just a matter of time of how it's going to show up. And something I learned about vitamin K is that if you've got a woman with a lot of wrinkles, she's probably got a vitamin K deficiency. So I prefer sunlight exposure, of course, and food bases, but supplementation is always awesome. I supplement personally. I supplement a lot of patients. Vitamin D is a hormone, not a vitamin, and it's made from cholesterol. So if all the other hormones are low, probably going to be low because synthesis isn't up. Optimally, this changes all the time, 30 to 50 nanograms per ml on blood labs. That's what I look for. That's from the American Association of Clinical Endocrinologists. I like 50 to 80 because I'm dealing with pain, and I think vitamin D is really nice to help with pain. And I dose about 1,000 I use a day with food. I do like the Designs for Health high potency emulsi D3 if you just want vitamin D. It's 2,000 IUs per drop, which is so cool. Or they have this emulsi D3 synergy liquid that has vitamin K1 and K2 in it. I like both of those, and those are available in Fullscript. Vitamin C, it's a gimme, super helpful in collagen synthesis. Again, if we're thinking bones, if we're thinking collagen, I mean, that's my world, right? But vitamin C also helps with testosterone. It might be acting as an antioxidant, i.e. an anti-inflammatory in the system, who knows? But there is some literature to support vitamin C and testosterone levels, especially, again, if they heal poorly, especially if they are active. Oh, that should be an if, not an S. It should be an F. So especially if they're active, especially if collagen synthesis is desired. Obviously, vitamin C and zinc are critical in collagen synthesis. I think it's always desired as people age. And I dose 1,000 milligrams a day of vitamin C. And I like Designs for Health Stellar C. I have no association with Designs for Health, by the way. I just sort of adapted their products over the years, and I like them. I like their packaging. I like their company. I like their education. So but I don't have any affiliation. And again, you can find that on Fullscript. The Stellar C has like quercetin and some other antioxidants in it. So it's just a nice, well-rounded product. Rutin, I think, is in there, and some others. But it's a nice, well-rounded product. Magnesium, hands down my favorite supplement in the world. I think it's wonderful. I like to eat it. I like to smear it on my body. I think it's great. Again, treat the person in front of you regarding form. I don't get too hung up on form. I like the Designs for Health Neuromag. I think that form of magnesium in particular, I treat a lot of people's brains when I treat their pain. So I treat the pain by treating the brain, because pain is in the brain. So I am most often interested in decreasing neurogenic inflammation and brain inflammation. So I use the form that's in Neuromag. But generally, most types of, so treat the person in front of you, depending on the form. Most types of magnesium, I think 600 milligrams is going to be helpful. You could do it at night, but know that it interacts with zinc. So maybe you don't want to do the two together. But 600 milligrams, or depends on the form, because I think the Neuromag is like 3, 4, 5, it comes out to like 400 or 500 milligrams at 3 capsules, which is their suggested dose on the bottle. So I don't know, it depends on the product. I dose according to symptom relief for the person in front of me. Topical can also be really helpful if tolerated. It can be a little caustic on the skin, but I think it's really nice to add to a carrier oil if that's the case. I use it straight. I like the burn. I like to work out. I like to take a hot shower, end with cold, smear myself in this and go to bed. It's awesome. And you might add a little lavender or something for, aromatherapy, aesthetic or healing, whatever you believe about essential oils. But just know that there are nutrient interactions with magnesium. We're so deficient in magnesium, period. I think everyone is. And, depression, all kinds of symptoms are due to magnesium deficiency, but it does interact with zinc, fiber, protein, and vitamin D, all of which are super important for testosterone, ideal testosterone production. So just be cognizant of that. Creatine may work by converting testosterone into DHT, the more active form. Be careful with hair loss, because high testosterone levels in women can, if you are supplementing actual testosterone prescription, hair loss is a concern. Creatine may cause weight gain, but it definitely can help with strength and fatigue. So I like, again, Designs for Health has some nice products there. They have a nitrous oxide synergy, which helps boost nitrous oxide levels, great for working out. And then they have a Cre-alkaline, which is nice. It's a high potency. There are a variety of herbs with varying data on how good they are. So here are just some of them. Another product I like is Libido Stim F by Designs for Health. They have a male version. There are lots of products. If you go onto Fullscript and just type in libido, there's a ton of different herbal products that you can choose from. So pick your favorite brand, pick your favorite herbs. I know you all have your favorite herbs, but these are some of them. We don't always know how these work, but we know that they do impact women's hormones and notably testosterone levels. And this Libido Stim, I think, is a great product. I have used it on a lot of patients and myself with great results. It's not the end all be all, but it is a nice adjunctive. The maca in there is wonderful. Do not forget about thyroid and progesterone. Don't forget about these hormones. They work in concert. Low thyroid and low progesterone can really look a lot like low testosterone and vice versa. And I think you kind of need them all. So If I do prefer thyroid hormone prescription supplementation, but if you can't do that in the state that you're in, or you're not a prescribing physician, there is a thyroid synergy product by Designs for Health. There's also a thyroid, I think it's called thyroid support or thyroid synergy by Pure Encapsulations I like. It's got some selenium and some other things. Some of these have glandular in them. Up to you how you want to work with that. I really do prefer the cleanness of a prescription, but again, up to you. And then progesterone, I like to do 3 weeks on, 1 week off. Delivery, again, depends on the patient in front of you. Do you want to give them oral micronized because they need to sleep and they have anxiety? Do you want to give them topical because it's easier and they're thin and it won't glom up in their fat stores? That's all up to you. But there's different routes. And then and those creams are available on Fullscript as well. Adrenals, don't forget the adrenals. It all comes down to the adrenals. This is where women's testosterone is produced after those ovaries start to putter. So support the HPA axis. This is where, if this crashes and burns, all of it goes to hell in a handbasket. And the testosterone dips along with everything else. So support the adrenal axis and make sure that that's a constant. As for lifestyle, these are non-negotiables in my world for men and women. Strength training, absolutely non-negotiable. If you want to know more, go to my website, go to drtina.com, grab my free book and read chapter 3. Talks all about strength training and it's all referenced. Sleep is critical for testosterone production. Blood sugar regulation, adequate healthy protein and fats, decrease the cardio, it burns people out, decrease their adiposity, especially the dreaded gut. This is more often seen in men, but women get guts too. I don't have a better word for it. You know what I'm talking about. We get that gut. A lot of it comes from drinking and carbohydrates, but that is not going to be helpful for your testosterone. It will start to help you aromatize things into estrogen though. Decrease alcohol, especially IPAs and drugs, recreational drugs. Marijuana is known to decrease testosterone in men. Alcohol is the kiss of death for hormones, and definitely decrease stress. However you want to go about that with the patient, but it is absolutely, it's not enough to say, oh, you got to decrease your stress. Give them some resources. Stress is the root of all evil. I am learning quickly. It's very tolerable when you're younger, especially if you get a little bit addicted to the cortisol. It's really easy to just run through life running on stress, but you hit your 40s and it just crashes and burns, trust me. And that is not a fun place to be. You can't run on stress. Foods that raise testosterone, this is my go-to. I love protein, obviously. Animal sources are my preferred. That doesn't mean you have to follow my guidelines, but I do suggest that to my patients. Eggs, eat the yolk, please. That's where all the goodies are. Pomegranate has been shown to increase testosterone levels. Ginger, fatty fish, oysters, leafy greens, onions, garlic probably as well as onions, I'm sure, since they're so similar. My friend Dr. Sam Madeira is a testosterone expert for men. And I just asked him off the top of his head, I'm like, what are your top 5 foods, my friend? And he said, just rattled them off to me: grass-fed red meat, eggs, healthy fats. He likes fatty fish and sardines. I think sardines are a nice source because they're not going to be so full of heavy metals. Brussels sprouts and or broccoli sprouts, and then red radishes. That was his list. So when in doubt, encourage your patients to eat, to lift, and to sleep. And don't forget to review prescriptions. What are they taking? That's most important. Statins, opioids, steroids like corticosteroids. These are all critical to look at in the patient, but do not forget what their male, if they have a male sexual partner and they're not using condoms and they're absorbing these men's semen, please, please, please consider what the men are taking. I will tell you this from personal experience. I have had partners on different pharmaceutical drugs and they definitely impacted my hormones. The most recent was a partner who was on Arimidex, and because he takes testosterone therapy, and all of a sudden my estrogen bottomed out over a course of days. I was like, whoa, back up. Are you on Arimidex? So just know that what men are taking goes through their semen. We don't know what form, we don't know what kind of metabolites, but it definitely, I have actually had increases in my testosterone due to this. I've had patients report getting thrush or getting vaginal infections when their partners were on antibiotics. So please consider in your female patients, what are their husbands taking? Because most men by that age, in their 40s and 50s, are on a variety of pharmaceuticals, and it will impact their female partners. This might be the most important thing that you take away from this presentation. Is check your female, you're treating them for all these things and no one's looking at what drugs their husbands or their male partners are on. And then above all, reduce inflammation, reduce stress, and consider hormonal replacement, especially if pain is present. Meaning, if you can't prescribe testosterone, if they need it, please find someone who can for them, because it's going to make all the difference in their joint pain and their joint health. So I will open it up to Q&A now. Please follow me on Instagram. And if you need to email me, you can reach me at assistant@drtina.com. I am probably best to be reached on Instagram, though. That's where I hang out, and that's where I share all my good stuff. So anyway, without further ado, thank you for having me. And if you guys have any questions, I'm happy to answer them. I'll check out the link now. Oh, there are so many. Okay, let me see if I can make this bigger. Oh, geez. Tiny little, give me a second, you guys. Any thoughts on a new spearmint-derived phenylytic compound positioned for cognition, possibly decreasing testosterone as an unintended? Yes, I did find that in my studies that spearmint and mint can decrease testosterone. So I would definitely, I thought that was interesting myself, because I eat a lot of peppermint. I do a lot of peppermint capsules for my stomach and for my digestion. I do these little like doTERRA peppermint beadlets that I like for my breath. And so that is a good point you bring up. Is there supposed to be audio? Matthew asks. Hopefully that got sorted out for him. For those of us post breast cancer really struggling with zero libido and vaginal atrophy, is T therapy an option? Yes, Kirsten, it is. There is literature to support that it's safe, and it depends on the physician who's willing to prescribe it for you, and then also tracking your estrogen very carefully. But yes, that was something that I came across. I didn't even want to bring it up in this because I thought it would be too much, but it really sounds like for women, particularly those who are on estrogen blocking drugs, that testosterone might be a nice option if you have the right doctor and you're obviously monitoring all the right things. What do you do if you've had numerous hormone panels done and nothing has worked? Post-menopause, no energy, no vitality, no memory, brain fog, losing hair, no sex drive, and on leaky gut. I would run a different, I don't know. It depends on what your tolerance is, or if you could find a doctor who's willing to prescribe for you and just try it. I am that kind of doctor. And actually, I found a lot of interesting comments by physicians in my research for this. I didn't include them all, obviously, because it was like the rabbit hole, but there were a lot of MDs who do bioidentical hormone replacement that when they were asked, they said they don't even test women for testosterone. I do, because I don't want my license revoked, and it's a Schedule III drug and you need a DEA license to prescribe it. But they were saying, like, if women present with these symptoms, they actually dose the testosterone and then they check levels. So to see how they're coming up, they don't even do a baseline. So for you, Tony, I would encourage you to find somebody willing to prescribe for you. What is the best test for testosterone? I don't know that. Everyone I ask has a different answer. I think serum is quick and easy. That's usually how I do it. You can do urinary, you can do salivary, but if they're doing a topical testosterone, you've got to take that into consideration because that'll change salivary. So I usually just run serum and go off symptoms because I'm dealing with pain. Here's the thing, you guys, when I took my first dose of testosterone, within 5 minutes, all my pain went away. Like, I'm talking 20 years of chronic pain just gone. And I was like, what? And I remember waking up the next day and wondering where all my pain was. I was so used to hip and back pain. It was gone. And the sense of calm that came over me within the first 24 hours was amazing. Not only was I calmer, but all my depression lifted. And I'm talking this low grade sort of depression that I have had lingering around me for about 20 years. So this all started for me. Things worsened after I had my daughter, who's turning 20 in a few months. So like maybe my testosterone dipped out in my 30s. Will we get a link for the replay? I don't know. You'll have to ask Cameron. I can't hear anything. That's on their end. Best clinical signs of testosterone, definitely. That will help you distinguish it versus other hormones. I don't have a best clinical signs. I just know in my practice, I was seeing pain and I was seeing anxious people.
Just to follow up on that last question there, Tina, we will be sending the replay to everybody who registered in the next few days. We'll just have to edit it a little bit and then we'll be sending it out.
Uh-oh, did I say something inappropriate?
No, we're just gonna put pretty pictures on it.
I'm just kidding. I tried to keep my curse words out of it. Okay, I'll proceed. So the best clinical signs of testosterone deficiency, I think the ones I listed. I mean, here's my thing. I would start there because all my signs of estrogen deficiency went away. I've had other women report this. I used to do all things PRP. I was injecting PRP into vaginas a long time before there was an O shot. And I will tell you, with testosterone, all that vaginal atrophy, all that vaginal dryness goes away. So we could call that an estrogen symptom, but ironically, with testosterone therapy, it goes away. The reason I got tipped onto doing testosterone therapy for myself was because my doctor gave me testosterone cream vaginally, and I noticed a significant improvement. And I was like, I wonder what this would do for the rest of my body. So I don't think that there are best clinical signs. I think you just have to know your hormone replacement therapy well. That's not something you learn in school, and it's not something you get on a weekend course. You've really, really, really got to learn hormones. But maybe you do, Myrna. I don't know. So how to prevent endogenous testosterone diminishing when taking synthetic? Don't have an answer for that. Don't care, honestly, because if you can give a woman her life back, I have never met a woman who's taken testosterone who didn't say, oh my God, this was the best thing ever. They all are like, oh my God, thank you for giving me my life back. This is the best thing ever. So taking it, I really don't care if my endogenous testosterone diminishes. I'm in it for life. However, I got to get it. Here's another thing to consider. Women need micro doses of testosterone. I mean, at the high end, maybe a quarter of what men need. Where in nature do we get testosterone generally? And this is going out on a little off topic here, but my theory is we get it from semen. We get it from healthy, vital men who and I'm not saying everybody has to be in a male-female relationship. That's not what I'm getting into. I'm just getting into like just we're fancy mammals here. My background is in animal behaviorism. So if men are healthy and vital and have adequate testosterone levels, we would probably get that dosing through semen. We're not getting that. We don't have a lot of healthy men out there anymore. And a lot of them are dealing with very low testosterone because of the xenoestrogens in the environment and blah, blah, blah. And if you want to know more about that, I defer back to Dr. Sam Madeira because that's his thing. But I'm telling you, I don't think that the way things are supposed to go are going. And there are studies to show that women who use condoms actually have higher rates of depression and anxiety. So there is more to semen than just testosterone. There's zinc in there. There's immunoglobulins. There's all kinds of good stuff. And so I wonder, I'm just theorizing here. I don't have any hard science because there's not a lot out there, but I'm wondering if that's not a way that testosterone might be getting dosed to women if things were going well. Thoughts on high cortisol, likely not low T. Cortisol blocks the testosterone receptor. So if someone has high cortisol, they'll probably have low testosterone. What about using DHEA first before testosterone? Absolutely, worth a try. I did that and it didn't work for me. It worked okay. It gave me a perk. It gave me a leg up. So I would always encourage DHEA and progesterone before testosterone, but if there's, and thyroid, of course, and adrenal support, but if they're not coming around, don't delay, especially if there's pain or joint degeneration. Ways to increase testosterone endogenously. I hit that on a slide. LabCorp suggests a range of 7 to 40 is normal for postmenopausal women. A client of mine is 25, but is expressing most of the symptoms. Is this normal? It's up to your risk tolerance and your state and what you're comfortable doing. I would prescribe and see if symptoms abate. For me in my practice, pain was always what brought people in the door. So it was real easy. I would dose thyroid until their pain went away or their migraines went away. I would dose testosterone until their pain went away. So whatever you feel comfortable doing, I'm a little bit of a renegade, and I trust that I can defend my reasoning in court. And I have a good lawyer who also can defend my reasoning in court. And so I am all for giving a woman the relief that she needs desperately. And if that requires that I get in a little bit of trouble, then whatever. I didn't come to medicine to play safe. So I would dose and see what they do. If all those symptoms abate, you now have proof. And then what you need to do is just be diligent about testing on labs to make sure she doesn't go into crazy zones high, and then obviously track symptoms, side effects, which would be like hair loss on the head, hair growth. Hair growth on the face is pretty common, but it's all up to their tolerance too. I've had women who've had serious engorgement of their clitoris and they loved it. They were like, I literally have a mini penis and I love it. So whatever floats people's boats, like, you know, as long as you're not having other side effects happen, it's really not a very dangerous hormone, in my opinion. It's not the villain it's been made out to be. Danielle asks, is it possible for a patient to have all of these symptoms of low T and be diagnosed with PCOS? That I don't know, because I don't do a lot with PCOS. But I could suppose that they could have high androgens and then cellularly they're not receiving it, that there's a cellular receptor issue, or it's being bound up by sex hormone binding globulin or something. So possibly, but I don't know if giving more testosterone is the solution. I don't do PCOS. It's never been my jam. So I don't, most of the time women come into me and they're past that. They're in their kind of their boomer years. Tony asks, I'm going on testosterone. Happy to be the guinea pig for anyone. Thank you for an excellent talk. Yay, Tony. I would love to hear back from you and tell me how you feel, because man, it changed my life. It just made me again. I just was like, the clouds have lifted and I'm back. So it was really powerful. Do you know if she will be at the Integrative Healthcare Symposium next month in New York? Is that if you're referring to me, Sharon, I will not be there, but that sounds super fun. I just learned about it. Is that DHEA dose once daily? Yes. Start low and slow. I'm a big fan of slow and low with everything, with hormones. And with regenerative injections. I don't like to smack people with things and then have them get side effects and be scared away from the therapy. So I think that with DHEA, especially, women, pain and vanity, just here's a clinical practice pearl. If you can tap into someone's pain or their vanity, you will have a patient for life. But and they often go together, but if you create pain or you disrupt their vanity, they will hate you, especially if you're a man giving a woman acne. So be very clear, because you don't know what pathway they're going to go down. Be very clear with them what their potential side effects are. For women who go down the testosterone path in particular, that is the second part. Is that on I think you're referring to DHEA. Yeah, I don't know. DHEA has been great for a lot of people, but it's not always the end all be all. Sometimes you got to add in a little bit. But still, if it's raising testosterone levels, then our goal is achieved. How much vitamin D with the EPA DHA supplement do you recommend? That D is 1,000 milligrams. I think that's in there with that Douglas Quell product. I like it because it's kind of all in one, and it's in a fat form. So, but I might do extra D on top of it. Depends on your patient, what you need to do, where you live. Yes, Dr. Edward, the PowerPoint will be shared, according to Cameron. Do I test for copper toxicity? I don't. I've done a lot of zinc over the years with people, and I've never tested for copper toxicity, but I know it's a real issue, and I've had people tell me that it is. If they start developing symptoms, of course I will. And most people don't stay on their supplements forever, especially things like zinc and vitamin C. They think those are like throwaway supplements, and so they'll stay on them. I put everybody on those during their treatment plan. So their treatment plan might be dropping my mineral water. Their treatment plan might be 3 rounds of PRP over 6 to 9 months. And so they generally will go, I don't see them after that, right? I don't do a lot of the general stuff anymore. So the way my practice was since 2013 is if I started somebody on hormones, I always punted. I would get them started so that we could get them optimized so I could inject them. And then I punted. I did not manage. So I don't know with a lot of these things. They were off with someone else. Generally, I sent them to Heidi Peterson, so she would know. Is zinc recommendation regardless of blood test results? Yes, especially if they have little white clouds in their fingernails. I think everyone needs zinc. I think everyone needs zinc and everyone needs magnesium, but that's me. I don't test for that kind of stuff. I just give it to them and see how they feel. K1, right? Not K2. That product has K1 and K2 in it. Does Dr. Moore measure vitamin K levels in patients with wrinkled skin? Nope. I think everyone's deficient in that too. Again, I practice a little. I'm not a big tester with a lot of this stuff. I'm not afraid of fat soluble vitamins. The next question is, do you find ferritin is high with low testosterone? I have seen that in correlation. No, but I have seen ferritin be high with high testosterone. So that's very interesting, Nicole, and I will definitely take note of that. So ferritin elevates with low testosterone. Well, ferritin can be an acute phase reactant more than just a iron storage molecule. So maybe they have inflammation and that's what's driving the testosterone down, and then the ferritin gets driven up. I don't know, but that's interesting. Does Dr. Moore see excess facial hair growth in women who use supplemental creatine? I have not seen that. I have never dosed them high enough, and most people, again, don't stay on that stuff. I'm usually treating them for 6 to 9 months, and then unless they need more injections, I don't see them again, and I don't manage their general care. I'm very clear about that in my paperwork. I treat them, and they are there for injections for me, but I do all the things to get them started, or I might punt to do the things to get started. I just wanted to share that creatine has some scientific backing. Marijuana decreases testosterone in men, yes, but I don't know about in women. They don't have a lot of studies on women and anything testosterone. So a lot of the recommendations I gave you were based on men and testosterone, but I'm assuming we're the same human, so it might work similarly as far as supplements go. I have had a patient with very low testosterone and DHEA. She's 40 and gets horrible cystic acne and agitation at even low doses. That sucks. Testosterone 1 milligram and DHEA 2.5 milligrams, as well as similar reactions to maca and other that sucks. Yeah. That I don't know what to do with. That is tricky, and I had a patient like that, and even adding fish oil in gave her terrible cystic acne, and it was just round and round and round we went until I finally referred her out to somebody who was better at hormones. I am not a hormone expert. I take that back. I'm pretty good with hormones. I don't get into the weeds with them. I use them as a way to optimize people's tissues and to get their pain down. And again, I punt. So somebody like that, I would definitely punt. I don't do that. When it comes to women and hormones, it's like trying to hit a moving target and it's all over the place. So I bless all of you who are good at it and who have the tolerance for it, but that is a tough one. I bet that is something about her pathways. I would, run one of those tests that looks at the downstream pathways. Can women get a boost of testosterone from a man's semen? Yeah, I hope so. That was a good, see, Pamela was on it before I even mentioned it. Sharon says, thank you. Yes, thank you, Sharon. Thank you for coming. Megan says, can you explain the interaction with zinc and magnesium some more? I think they just compete for the same receptor. So it's kind of like don't take your zinc with iron or don't take your magnesium with calcium because they might compete for the same receptor. So in my reading, I used to always take zinc with magnesium. I thought the combination was brilliant, but I think they might actually out position one or the other on the receptor. So you might not get good absorption of one or the other. You order just blood testosterone testing. Yeah, so in my practice, it's like I said, it's quick and dirty. I'm not there to do hormone replacement therapy with people. I'm there to get them out of pain now. So, and then I punt. So they get a whole thing that says you're going to get 30 days of this hormone. You need to have your labs done in 30 days, and then you will be referred out. And they know, so they get on someone else's schedule, like they know the whole jam. I don't do a lot of the long-term management of this stuff. But I know that Heidi Peterson does a lot of testosterone with great results. So how do you check levels and how often? It depends on your risk tolerance. I try to get symptoms to abate before I run labs because what's the point otherwise? Or if I start seeing side effects, I will run sooner. So I don't have an exact answer for you. It might be 1 month, it might be 3 months. And as you know, patients aren't always compliant. You give them a lab order, they lose it. It's a month later, they need a new prescription refill, they haven't done their labs. And then 1 year we tracked it. It cost me $30,000 in staff time just to chase down patients to run their stinking labs and get on the schedule again. And with testosterone, I don't mess around. I have them sign a contract. Don't ask me for the contract because I don't know where it is anymore. But I would have them sign the contract that would say, if you don't do these things, you will not get any more. And so they just would run out, and that would be that. So I have very little tolerance in my practice for people wasting my time or my staff's time, and I'm pretty hardcore about it. I'm not as nice as a lot of you. So they know the deal from the beginning. I give them the dealio. I'm very clear about it. And I'm like, if you don't play by my rules, you get nothing. So best prescription for testosterone therapy. After looking at all of it, you can do topical, but I think it gets messy everywhere and it can end up on the dog and it can end up on the kids and everyone else. Probably not bad if it ends up on the husband. Most men could use some more. Obviously Cypionate is an option. It's clean and easy, but that's not, a lot of people don't do that. I have done it. I have used it. Great results. But it can aromatase, so you might end up with some belly fat. The whole goal is that you lose the belly fat, right? When you put someone on testosterone, they tend to lose belly fat. But the pellet, I like the idea of the pellet, although I just had a colleague have an adverse reaction from the pellet where she had a uterine fibroid grow robustly after receiving a pellet. Once the pellet's in, you can't take it out, and you just kind of have to wait it out. I had another patient complain about a pellet because I didn't do the pellet. I had her sent out. She complained that her libido was so strong that she just, like, her husband couldn't deal with her, and it was really uncomfortable for her. Like, she couldn't sit because of just sitting in a pair of jeans would stimulate her clitoris and send her into a tizzy. So and she's a pretty conservative gal, so this wasn't like, it was just a lot of interesting symptoms. But I think 100 milligram pellet is kind of a godsend for a lot of people. How do I dose the magnesium? Yeah, just like it says. I do 3 caps on it, and however you want. Dose the person in front of you. You know, sometimes I give people so much magnesium, I take them up to bowel tolerance and then back off. I am all about treating the person in front of me, and I'm generous with my dosing to make sure that they get symptom relief based on what I'm going after. Transdermal testosterone is the next question. I think I just addressed that. I addressed the testing question. Reasons for low T in your 30s, like no serum testosterone, maybe stress or prolonged illness. Those would be the 2 main things I would think about is, you know, have they been rocking like a herpes virus? Like for me, I got cytomegalovirus when I was 19. It almost killed me, and it removed me from college. It was bad. And I don't think I recovered from that. I think my adrenals tanked, and then I got pregnant years later, and, you know, on and on it goes. So I think that it can just be a culmination of things. And head injuries are another big one. Cheerleaders, I've seen it in cheerleaders, young women in their 20s with low T because they fell on they were the flyer in the cheerleading squad, meaning they got pitched up in the air, and cases where they got dropped, and then they would present with psychosis, end up on a bunch of antidepressants. Antidepressants can tank out testosterone, so like years of antidepressant use, all kinds of reasons. Would you also see, Andrea asked, would you also see elevated sex hormone binding globulin in a female when all of the hormones are in a good range? This includes she is experiencing hip pain, knee pain. I don't know. There's a lot of reasons for sex hormone binding globulin to go up. And one of them I just learned from Dr. Deborah Rice, who is a colleague of ours. She showed me some literature saying that people who are in ketosis or very low carbohydrate diet will have elevated sex hormone binding globulin. So I don't quite understand all the reasons for high or low sex hormone binding globulin. I think it's very individual for a person. So I don't have a good answer there. I answered the how do I prescribe testosterone question, and I answered the pellets. Yes, pellets can go awry. Thoughts on soy? I am not a big fan of soy. I feel like soy and beer are like estrogen tinctures. And I guess if a woman needs that, go for it. I don't like how I feel on estrogen, and most of my gal friends don't also. We are kind of like low estrogen girls, and so I have always avoided soy. Besides, a lot of soy is genetically modified, and I'm not a big fan of it. Myrna says she's heard of women using spearmint for hirsutism. Oh, smart. Okay, so yeah, peppermint lowering the androgens there. Do you recommend a period of time off of T like you do for E? I don't know. That is a good question. I do like to pulse things. Like I post low dose naltrexone, I pulse hormones. I don't know, especially if you've got a pellet in someone, there's probably no time off. But they will tell you, for me, when my testosterone starts to get low, my pain comes roaring back and I get really, really cold and my sleep starts to get wonky. So for me, going off of it doesn't seem like a fun idea at all. And again, I treat people with pain. So a lot of my patients, men too, if they were out of testosterone, they would lose their marbles. Estrogen sometimes with women is such a pain mitigator. And so whatever the hormone is for them that they need, any time off of that, even a day with one patient, the one who got severe acne with the use of any testosterone, even a day off her estrogen and her pain would come roaring back. So, okay, so many questions. I'm trying to get through them. Linda says, T levels you mentioned is ideal. Is that serum or what type of testing? That was serum. When do you test testosterone in a women's cycle? I kind of do everything day 19 to 21, just because that's when I'm going to see all the things. I will either use serum or a Dutch test. I don't do salivary that much anymore, but days 19 to 21 gives me a look. But there, you can get real specific with things. I don't. I go off symptoms. I usually, if I'm going to test testosterone in order to prescribe, I'm literally just doing it to give me a reason. I have a reason. I have all the symptoms telling me she needs testosterone. I'm going to give her testosterone probably. I just need a lab test showing me we are low, normal, or low. And in that case, I am. But if she has normal levels, but all the other checkoffs boxes are checked, I'm going to give her testosterone. Do you work virtually and are you taking new clients? I'm not. I actually closed my practice and I'm only seeing a few patients that I have kept that I've had forever, and everybody else I referred out, but thank you for considering me. I don't treat anymore. I just train other doctors in prolo and business now. So, and I'm just taking a break from practice for a while. So yeah, let's see. Jana says that she thought her achy shoulders were a result of an oxalate result. Yeah, it might be testosterone. Yes, it might very well be testosterone issue. Anita asks, how fast can high dose zinc, boron, vitamin D, K, basically only nutrients, work in raising the hormone? I don't know. I don't know. I really don't know. I don't try to hit everything at once. You really just have to, each person's different. It depends on so many factors inside their body and so many biochemical processes that are going on that you just have to play with it and see what's happening. And if it doesn't work, I would give it like maybe 90 days to see. And again, go with symptom relief. Forget, everybody gets so hung up on labs, and I think labs are great, but symptom relief is critical, and that will stand in a court. If you're monitoring with labs and you're being safe and you have symptom relief, you're not going to get in terrible trouble usually. And don't quote me, but talk to your lawyer. Of course, you should all have a lawyer if you're practicing on real humans. If they can defend you on that, then you're good. My lawyer's not taking any new clients, but she's very good with functional medicine, and she kind of knows the laws in Oregon like nobody's business. So Jacqueline asks, is there a time period post-menopause that you would not start hormone supplementation? I've seen literature talking about risks outweighing benefits if it's been more than 10 years. Oh, gosh, that's a hard question. Again, I'm dealing with people's pain. So seeing a woman crippled in my office at the age of 55 with bilateral hip issues and low back pain, and she is used to being a vibrant, active woman, and she no longer can have intimacy with her husband, and her husband's miserable because he hasn't had sex with his wife in God knows how many months or years. And this all came on abruptly. There was no onset of trauma. There was no fall. There was no nothing. Her hips went. I see this all the time. It's so devastating. I don't really care. I'd rather monitor them, let them know that, like, yeah, we're dealing with hormones and there might be some side effects. And I do empower all my patients to do their own research because they're usually pretty highly intelligent people. I only take patients who are strength training, so they're usually, their lights are on and they're on the tip already. They're generally biohackers or people who are already quite knowledgeable, and most of them are willing to take the risks. Although that article I shared with you, that Forrest, I forget his last name, he actually has a template in that article that's a consent form that you can look at. But again, run all consent forms by your lawyer. And then Linda says, how do you feel about the 24-hour urine hormone test versus something like the Dutch? I have no experience with the 24-hour, Linda, so I don't know, to be honest with you. I don't want to answer that. Sharon asked, do I like Dutch for testosterone? It depends. So I might run blood, like I said. It depends on the patient. What if they have violent outbursts on testosterone but still have chronic pain? I think that people's violent outbursts are because they are aromatizing into estrogen. I don't actually think testosterone makes people aggressive. In fact, testosterone made me calm as a cucumber, and I have seen that a myriad of time with patients, men and women. They get super calm. Now, men, if they start to aromatize, they can get bitchy. They get aggressive and bitchy, which is super fun as the practitioner to deal with. But that's usually because their estrogen's going up. So Tammy asked, what testosterone supplement do you recommend? I think I covered that. I think I covered routes of administration. Do I usually, Pina asked, I like your name, Pina, that's a cool name. She said, do you usually prefer to start with prescribed testosterone versus using the botanical mix? I do both. I will do both. I really like prescriptions. I became a naturopath so I could prescribe drugs and hormones. I'll be straight with you. I really, really like I think prescription hormones are very clean. and we know exactly what's happening. And it's, for me, like I said, I don't get the people who just discovered prolotherapy. I get the people who have already done prolo and everything else with everyone else in town, and they end up in my office because they're referred to me, or they found me somewhere online because of my online presence. And I don't have time to mess around. So I go straight to the hormones. But if you don't have the right to prescribe, or you're afraid to prescribe testosterone and you don't know how, consider obviously slow and low with the botanical mix and the other nutraceuticals. That lifestyle slide is, like I said, non-negotiable. I don't care what you're doing. If they're not doing all the things on that slide, they're not going to get good results at all. So Jacqueline asked, if sex hormone binding globulin is also elevated and possibly binding up the testosterone, is supplementation still going to be effective? It depends on if you dose high enough to overcome the sex hormone binding globulin, and then figure out why the sex hormone binding globulin is up. Although I can't always figure that one out. Like I said, that one stumps me sometimes, but I will just dose past it. I dose until symptom relief. So Kelly asked, what route of the testosterone did you take, and what was your baseline testosterone blood level? I will defer on that. That is personal. It was low. It wasn't terribly low, but it was low, and it was amazing, the results. So let's see. This is a question about facial hair. This patient's had facial hair since her 20s, and now she's in her late 50s. She was athletic in her 20s and 40s and less. You know, sometimes that facial hair, I forget the term for it offhand. I have it too. I was anorexic when I was young, and I grew that peach fuzz. So I don't have black facial hair. I have like white. I have a white little fuzzy beard. It's something that anorexic girls get. It's something female athletes will get, especially if they dump their hormones out completely and were very thin. A lot of thin women will get it. So that, I don't know if that's what you're referring to, Mary, but if that's the case, don't worry about that. I don't think testosterone is going to make that worse. And if it does, I'm telling you, getting that hair off my face is easy. It's fine. I would far prefer that than having chronic musculoskeletal pain and all the other symptoms that are not fun. How long do you treat for? Life. I think this is a treatment for life. Let's see. Tammy says, my testosterone was practically zero, as well as my estrogen and progesterone. I'm seeing ND, but she put me on both E and P, but no mention of T. See, that's the thing. No one's talking about T. She mentions hair loss. Is low T implicated in hair loss at all? I think so. I think that I've seen that in men. One of their cardinal symptoms for bringing them in, asking about testosterone replacement therapy, is that they had low T. And I did not look that up in the literature, but it is in the book, The Secret Female Hormones. She talks about hair loss being a low testosterone symptom. So a lot of doctors don't know about testosterone, and they are scared of it. They're scared to prescribe it. So you might have a naturopath who is not interested or doesn't know, and maybe this webinar will help. I don't know. It's hard to say. Karen says, do I have to take HRT, or can I take SUPs only? I have no idea. Will testosterone therapy help pain during intercourse? Yes, because it will make your, so it's testosterone and estrogen convert readily into one another. And so you might have a amelioration of a lot of the vaginal symptoms of low estrogen. It might actually be low T. And so then if you can get the vagina juicy and slick, it won't be so painful, hopefully. But when it's low in T or E, it'll just dry out and sort of shrink away, and it can be very painful. Luana says, I know this regarding women, but can men with BPH and pain also be supplemented with test? It depends on the man and the level of BPH, for sure. Any concerns with long-term use? Yes. I think there's concerns with long-term use of all hormones, but you just have to go on a case-by-case basis. Shelley says, my hormones were compromised by years off of mold toxicity. Yeah, mold will definitely tank out your testosterone. I don't have a recommendation. I would work with your doctor. I do think pellets are not a bad idea, was the next question. I feel like I've addressed a lot of these. Raquel, I don't have an ideal range for someone in their 30s of testosterone, because there are no specific guidelines. So I would do some further research and decide. But again, I'm going off symptoms and labs. So if someone presents with the symptoms, I'm going to do some further investigation. Let's see. I'm trying to figure out what country am I? I am in Portland, Oregon, US. Let's see. I don't have a recommendation for reducing hormone sex-binding globulin because I can't seem to figure out, I was taught low protein or high protein diet, low carb diet, but then I also now have literature supporting that that will actually raise it. So I don't know. Let's see. Rachel asks, what's an example of a physiologic dose of tea in females in your world? It is about a quarter to a third of what you would give a male. So go off the male recommendations and then dial that down. Look up cancer. There's a question about cancer and thyroid. Look it up. There's actually literature to support that it lowers breast cancer risk. So I think that would be the big concern. And I mean, for everything I found, I am all for it. Well, although what you find online is very swayed. The medical establishment is not a big fan of testosterone for women. Have I had any experience with heavy metal toxicity and low T? No, but I would bet it would glom it up for sure. I think heavy metal toxicity destroys everything. What form of testosterone to use? I think I covered that. Does testosterone help with pain from RA? Yep, absolutely. I can't make dosage or product suggestions for you, but I would definitely consider that it's a player, and I would have your doctor work with you on it. What about saw palmetto? I don't have an answer for you on saw palmetto. Is pregnenolone helpful for increasing low T? I don't think so, but I love pregnenolone for pain, for sure, and anxiety. It's a neurosteroid. It's awesome, and it's awesome for pain. Let's see. Jill says, Rachel, I think, says testosterone increases plaque formation in the coronary vessels until it's balanced with estrogen. Your thoughts? I don't know. In my reading, I saw that it actually decreased plaque formation. So I don't know what the answer is. I think that, again, it's all case by case. So I run labs on patients and I treat whatever they need. So I can't give you a blanket answer. I can't give anyone here an exact recipe. I just more with this presentation wanted to shed some light on the topic. I don't have answers for you on exactly how to do it because I don't know your patients or their labs. I mean, I'm just saying this in general to everyone. Do women with high testosterone have the same symptoms as low? Well, I think with any hormone, not any, I mean, thyroid's not the same, but high levels of E will often look like low levels, and high levels of progesterone will often look like low levels. So potentially, yes, that they may look the same. Does testosterone contribute to higher mercury levels? I have no idea. Don't know. How would you deal with a postmenopausal woman who loses hair with testosterone but has 0 levels and pain? I don't know because I don't have the patient in front of me. I would have to look at them, and I need to put my hands on people, you guys, to be honest with you. My hands tell me a lot about their tissues, and I read a lot of symptoms based on what their tissues. I have such a high level of experience with my hands that like my hands tell me everything. So that's why I never did telemedicine with patients. I need to put my hands on the patient. I need to see them. I need to look at their vitality. I need to see the whites of their eyes. Oh yes, the peach hair is called Lunago or Lanugo. Yes, thank you, Myrna. Yes, yes. Thank you, everyone. How much do you dose pregnenolone for pain? That depends. I have heard anywhere between 150 to 300 on up. Dr. Anderson has a lot of good information on this. I would suggest you go check out his stuff. I can't tolerate levels that high, so I think I take like 50 milligrams at night, but it really depends. You can also just Google neurosteroids and pain, and you'll find information there. But again, slow and low, because we don't know what pathway the pregnenolone is going to go down, and we don't know what kind of wonky side effects they're going to have. So I dose it at night. I like a micronized version, and I defer to Dr. Paul Anderson for that. Can you give the reference again? I don't know where it is, Linda, for the high sex hormone binding globulin and low carb diet. I was talking to somebody at the Dutch labs, and she was discussing it with me. So I'm sure you could probably Google that too. So, okay, that's all the questions. I think we're done. And I loved being here. Thank you guys all for hanging on, and thanks for all your questions and your participation. It's been a real honor. Please go follow me on Instagram, and thanks you so much for coming.